do a little screen share. So just a reminder, you guys, I sent an email out about the NIM stuff. I do need that. I have to keep that on record for 7 years for the certificate in case the EMSRB or the Office of EMS comes and asks me about it. So I put a reminder on when we get to August 10th on the NIMS 700. I put like how to find your student ID number and that stuff again. Just make sure you're remembering that. Do the same thing. So let's see. Share my screen. So we have tonight chapter 14, 15, and 16. So I'm going to start with 14 here. Share my screen. Make you guys small. Make this big as I can. All right. So chapter 14 is cardiac and respiratory emergencies. Actually, let me stop. I'm recording, right? Just want to make sure I'm recording. Yes, I'm recording. Okay. Nightmare if I'm not.
You are.
The recording has stopped. This meeting is being recorded.
Yeah, perfect. All right. So chapter 14, cardiac and respiratory emergencies. These are things that you guys are probably going to be dealing with the clientele that you have. So if you have any questions, feel free to let me know, put them in the chat. Let's see. So the topics for this one, anatomy and physiology revisited. We've talked about the respiratory system, the cardiovascular system, and then we'll talk about emergencies for both cardiac and respiratory, the common ones that we see as first responders. Obviously, the next level up, when we get to that EMT level, they get way more in depth with this. This is just kind of a broad overview of the different things that we'll see out there. So this is a frequent call that we get as a first responder. These are frequent emergencies that we go to. They are obviously potentially very dangerous and very serious situations because cardiac and respiratory, right? That's our breathing and our heart going around and around. So we've already learned the resuscitation part, CPR, defibs. If we haven't, we'll get more into that. So this chapter is going to deal more with like more specific complaints like heart attack, difficulty breathing, other conditions that affect the cardiac and respiratory systems. So revisited. So respiratory system, again, the cardiac and respiratory system, they work together to bring oxygen into the body, distribute that oxygen throughout our body, and then remove that waste product from the cells for disposal as we breathe it out. So air enters the mouth and nose during inspiration. Take that big deep breath in. It travels through our oral pharynx and nasal pharynx, right? So nasal pharynx is our nose, oral pharynx is our mouth. It gets down to our larynx, which is our vocal cords, down our trachea, the left and main bronchi. It goes down through the lungs. Air passes from the trachea and increasingly smaller bronchi. So if the bronchi, as it comes down and branches off, at the end of the bronchi are bronchioles. And at the end of the bronchioles are those little alveoli, these little sacs. This is where that gas exchange takes place. And we can have issues with these little alveoli when it comes to like COPD and stuff like that. So this is why people are having difficulty breathing. The oxygen is moved from the alveoli to the red blood cells and the pulmonary capillaries, while the carbon dioxide from the blood is then offloaded and discarded through when we exhale. So breathing does require energy and oxygen. So the key concept is to understand fatigue and respiratory failure in our patients. So the process of inhalation uses muscles. The intercostal muscles of the chest contract and our ribs move upward and outward. Our diaphragm muscle contracts and flattens. That makes it a bigger cavity. Causes negative pressure in the chest cavity while air enters our lungs. When we exhale, blow it all out. That is a passive process in which the muscles relax, allows our chest to return to a normal resting state. This causes the pressure of the chest cavity to be greater and the pressure outside the body, so then air flows out of our lungs. So the fact that breathing requires energy and the uses of muscles helps us understand people with inadequate breathing. So if the patient becomes tired, has additional work that's being done in order to move that air into and out of the chest, that's a problem. The chest wall begins to expand inadequately, and this causes breathing to become inadequate for our patients. They're not getting in the oxygen that they need, They're not getting rid of the carbon dioxide that they have to get rid of. So normally the muscles of the abdominal area, the neck, those aren't used when we breathe typically. So the use of those muscles during breathing is called accessory muscle use, which means the body is enlisting help of those muscles in order for it to move air around. Specifically in the rib cages right here, those are our intercostal muscles, the belly muscle, your diaphragm right here, any of our abdominal muscles in here, all of that. If you're seeing these retractions mid-clavicular, right around his neck by the clavicles, that means he's having difficulty breathing. Another sign this guy's sitting in is that tripod position. He's leaning forward. Again, that's another sign of breathing difficulty. So with these, they can have an altered level of awareness. They can be unconscious. They can be dizzy, faint. They can be restless. They can be anxious. They can be confused. They can be combative. They're not getting the oxygen that they need. So all of that is caused by what's called hypoxia or lack of oxygen. Cyanosis around the lips, eyes, fingernail beds, straining of the neck and facial muscles. None of this should be strained, just for people breathing normally. Flailing of the nostrils and pursed lips, trying to get that air out. Coughing, crowing, high-pitched barking, any of those sounds that we're hearing, wheezing, rattling, that's not normal. Tightness in the chest, like stabbing pains in some patients. These are the intercostal muscles I was talking about between the rib cages. And then the abdominal muscles right down in here is being used. That's not normal. They're in that tripod position. And then numbness or tingling of the hands and feet as well. It can happen. So all signs that we're dealing with somebody that's having difficulty breathing. And we'll talk more about, like, they're not able to get words out in full sentences. They're speaking one word at a time, trying to catch their breath, that type of stuff as well. The cardiovascular system revisited. So blood flow. So your right side of your heart, you have your right atria, your left atria or atrium, your right ventricle down here, and your workhorse over here is your left ventricle. So the right side of the heart again receives blood from the body and pumps it through the pulmonary artery, which is in the lungs, where it picks up the fresh oxygen that we're breathing in. Brings it back to the left side. This receives oxygen, full blood from the lungs, and it pumps it out to our body through our aorta, which is all the red. So our ascending aorta right here pumps it up to the top of us. This is your brachial artery coming out this way. And this goes down, this red one goes down into our trunk and legs, breaks off into the femoral artery down into our legs. This pumps everything up into our head and our brain. All the blue stuff is the veins. That's what's carrying the oxygenated blood back to the heart for us, and then we pump it out with the red. So the left atria receives that oxygenated blood. Blood flows from the left atria to the left ventricle. Blood flows through the system of arteries. It travels back to the heart through our venules and vena cava. So venules are just the smaller veins. So it's veins, venules, capillaries, arterioles, arteries. Blood then travels back to the heart through the venules and vena cava. Blood flows from the right atria to the right ventricle, and then it's pumped out into the lungs with the left ventricle. And that gas exchange takes place between the blood and the cells at that capillary level. Again, the capillaries are in like the alveoli, and then right between the venules and the arterioles. All right, let me go down here. So emergencies that can happen. These are the things we're getting called for. So MIs, myocardial infarction. It's a funny name, I get it. Also called an MI. This is when blood flow to one or more parts of the heart muscle are just completely stopped by a clot on one of the coronary arteries. So the arteries in our heart are called the coronary arteries. Since the heart muscle needs oxygen to function, this is a very serious condition that, if not treated, is going to result in death of the heart muscle. And like where it's clotted off, that muscle's not getting any oxygen, any blood, anything that it needs. So it's going to cause pain. And without us helping with that, the heart muscle is eventually going to die, and eventually the patient will as well. Angina pectoris, or angina. This is a condition in which the heart receives a reduced blood flow to its muscle. So it's usually due to plaque buildup of the coronary artery. It's also caused by small clots that become lodged in the coronary artery, but don't occlude it completely. There's still a little bit of blood flow. It's just a reduced blood flow. It causes hypoxia or lack of oxygen of the heart and results in chest pain or discomfort. In most cases, with people with angina, when it presents itself, when the patient's exercising or experiencing emotional stress, when the patient relaxes, sits down, usually the pain goes away or subsides, or it can go away altogether. If they are having a full-blown MI with that complete blockage or the stopped or the clot, and they sit down to relax, if they still have that intense chest pain, that's not angina. That's an actual MI that they're having. So that's kind of the difference. Um, it's hard to differentiate between the two sometimes, unless you have like a 12 lead or something like that going on. But it's not necessary that we do. We treat it the same way. Um, and then, so that's going to be with, we'll talk about this when we get to like some of the meds and stuff, but that's going to be with oxygen and nitro, aspirin, that type of thing. Um, Rhythm disturbances, not all of these result in death of a patient. The most serious rhythm disturbance is ventricular fibrillation. Sometimes patient will make a complaint like my heart's beating out of my chest, or I can feel my heart skipping a beat, that type of thing. These are signs of something serious, and the patient should be transported to the hospital. They're most likely in like VFib. So with these cardiac emergencies, not all patients present the same. Um, Not all patients who are having heart attack present with like having chest pain, is raining down in my arm, up into my jaw. They all come in a little bit different. Um, we could have 100 patients and there'd be 100 different ways people are presenting with this. It's just different complaints. The classic chest pain presentation can occur, but doesn't always. Um, Portion of those will occur. Women, people that are diabetic, and people that are elderly, like the population you guys will be seeing, tend to have more atypical presentations with this. So they don't really complain of chest pain sometimes. Instead, it's more weakness, shortness of breath, maybe they're nauseated. So those are the symptoms that we see in those folks. A lot of times with women too, it's like lower back pain. So if we're having somebody with shortness of breath, they're just feeling weak and maybe nauseous, we're probably going to do a 12 lead on them when we get there with the ambulance. Those are symptoms of an MI at that level. So in some cases that are out there, the only sign of a myocardial infarction is that the patient has a sudden cardiac death without warning, and that could happen too, like a widowmaker or something like that. They just collapse over. So things that we can look for, chest pain or discomfort, it may radiate, difficulty breathing, if they're nauseous or they're vomiting, weakness, if they're dizzy, sweating, cool, clammy skin, or if they have a feeling of irregular skipped heartbeat. These are things that we are watching too, because it might not be like that classic presentation of an MI as well. So we get our sample history. So with signs and symptoms for this, asking those questions on, are you nauseous? Do you see vomit anywhere? Right? Sign is something you see, a symptom is something they're feeling. Asking if they have any allergies, especially when we start to give medications like aspirin. A lot of people are allergic to that. Are they on any medications? Have they already taken their aspirin today? Have they already taken their nitro before we've gotten there? So are we what medications are we on? What are they for? Are we on a high blood pressure medication? Are we on Lasix? What are we on? So asking them what kind of medications, what they're for, and if they've taken them, because we're not going to typically give another dose of aspirin if they've already taken a full dose. Or nitro, we have to wait to check some blood pressures. There's things we got to do. Past medical history, what in their past has is similar to this? Have they had stents put in? Have they ever had a heart surgery? Have they ever had shortness of breath before? What kind of is revolving around this? What did they eat last? And then what led up to this? Were they walking up the steps? Were they shoveling snow? Were they just sitting there and it just came on all of a sudden? So we can start with our sample history. And then we can ask the OPQRST questions. We talked about this a little bit. So after we get our sample, Looking at our OPQRST. So onset, what was the patient doing when the pain came about? Were they at rest or were they active? Provocation, is there anything that makes that pain worse? Is there anything that makes that pain better? If they sit down, does it make it better? Quality, asking the patient to describe the pain to you. Is it like a pressure? Is it stabbing? Is it dull? Is it sharp? Is it achy? What does it feel like? Region or radiation or relief? Where is the pain? Does it go into other part of your body? Is there anything that makes it feel better? Severity, that's our 1 to 10 scale, right? On a scale of 1 to 10, 1 being it's really pain, it's not painful, 10 being this is the worst pain I've ever had, where are you at? And then time, how long has the pain been present? How long has this been going on? So we check ABCs. We're going to ensure that the patient has adequate airway, breathing, and circulation, correct any problems associated with ABCs as they're found. Remember that these are life threats that we do need to treat. So working from our system, working down on our sheets, we can consider oxygen for these patients. We can start with nasal cannula. If they're looking good, they have the minimal distress, okay skin color, pulse ox reading is above 94, we could put them on a nasal cannula. Patient who has a lower oximetry reading, like that pulse ox, they're in distress for breathing, their skin condition is poor, they're pale, cool, clammy, sweaty. We're probably going to put them on an auto breather at 10 to 15 liters per minute. We're going to update EMS, let them know kind of what we're doing, get our sample and our OPQRST, get some vital signs that we can give to the incoming EMS unit. Perform a physical exam. Well, if we get a chance to do that, if there's anything else wrong with them, maybe they had chest pain, fell and hit their head. Okay, we're not going to move them quite yet, but what is there anything else wrong with them? We're just dealing with that. Monitor the patient for changes in condition. So we talk about reassessment. So these patients are most likely unstable, so we want to reassess them every 5 minutes. We can ask them if they've taken any aspirin or nitro before our arrival, document that. If it's something you carry and you know how to use it, we can administer those and then transferring that care to the ambulance when they get there with that patient report. All right, cardiac, any questions on that? Feeling good? Okay. All right, respiratory emergencies. Again, this population you guys are dealing with, probably older, a lot of wide variety of respiratory emergencies going on, and probably multiple things. A lot of times we're going to be called to treat people that are worsening. They have a worsening of their current condition or their existing condition. As with cardiac emergencies, first responders are not responsible for, we don't diagnose exact conditions. If we know what the patient has, great, we can pass that along. The treatment for these patients, like cardiac, is going to be the same. Oftentimes, cardiac and respiratory conditions overlap each other, and because the two systems are in conjunction with one another. So they're having shortness of breath. Yes, that's respiratory, but it also could be cardiac. So this person sitting in the tripod position looks like he might be having trouble breathing. So there's a lot of different cardiac and respiratory disorders out there. In most situations, it's not important for us to identify them. We just want to treat the life threats that we're seeing. They're having shortness of breath, their O2 sats low, we can put oxygen on them, things like that. So common respiratory conditions that we'll run into, asthma. We'll talk a little bit about these. This is a disease that causes airway reactivity. A trigger usually causes the smaller airways to constrict. That reduces airflow, so it's hard to get air in. So triggers that are out there for people are allergies, respiratory infections, exercise, things that can induce that. Patients may experience shortness of breath. You're probably going to hear wheezing with asthma. They're going to be anxious. Like most people unable to breathe, they're going to be anxious. They probably have a prescribed inhaler. They know they have asthma that sprays a drug or a medication called albuterol into their airway. That medication relaxes and dilates the constricted airway and kind of does the opposite of what the allergen is doing. Chronic bronchitis. This is an inflammation caused by smoking or exposure to industrial chemicals, results in long-term production of mucus in the lower airway. So when I say lower airway, think lungs. When I say upper airway, think face. Like your oral and nasal airways, your upper airway, on your trachea into your lungs is your lower airway. Patients often have a productive cough and chronic breathing problems and breathing difficulty. So, a productive cough meaning they're coughing something up. What color is that? What color of mucus are they coughing up? Um, we're usually going to be called to treat these patients when the inflammation and mucus production becomes worse because they're having difficulty breathing. A lot of times they're also on home oxygen. So looking at what that's set at, and we can start from there and go up. Emphysema, this is in a block called COPD, chronic obstructive pulmonary disease. And so emphysema and chronic bronchitis are two of those, which is called COPD. This disease, emphysema, can also be caused by smoking, results in the destruction and breakdown of the alveoli. And we know why those are important now, right? Because that's where that gas exchange takes place. The alveoli, there's a reduction in the ability for that gas exchange to take place from the lungs to the blood. So super important to keep our alveoli good, right? That's where our exchange takes place. So COPD, the chronic obstructive pulmonary disease, like I was saying, that is chronic bronchitis and emphysema. So it's a classification of those diseases. Chronic just meaning long-term. Obstructive refers to the inability of air to move in and out of our airway. These conditions are usually worsened by respiratory infections that aggravate that chronic disease. So if they get pneumonia or something like that. Congestive heart failure. This is a problem with the heart that affects the lungs. The heart muscle weakens either from just getting old and being tired, or they've had an MI or a heart attack. Because the heart is not pumping as effectively, blood begins to accumulate either in the lungs or peripheral circulation, like your feet. This is why people are going to have like edema on their feet or fluid. When the left side of the heart is not pumping effectively, it can accumulate blood that creates a higher pressure in the pulmonary arteries, the arteries that go from our lungs up. This causes fluid to be forced from the capillaries into the alveoli, which then we know that's where that gas exchange takes place. So it makes a reduced ability to do that. When the right side of the heart starts to fail, fluid accumulates in places like the ankles, your abdominal area, and flanks, which is your sides of the patients who are confined to bed. So if they're sitting in a recliner, they're going to have water in their feet. You can kind of push in on it. Otherwise, it's going to be their abdominal area as well, and then their sides. It'll be full of fluid. That's where the pulmonary edema comes in. That's going to be in the lungs, and then peripheral edema is going to you're going to see that in the feet and the abdominal and the flanks. Pneumonia. These patients can be very sick from infection in their lungs. Usually, these guys are going to have a fever because it's an infection. They often complain of chest congestion and cough. The cough may be productive and bring up thick sputum from the lungs. Again, fever. They're going to feel weak and achy and complain of pain in their chest. So it might not be a heart attack, it might just be pneumonia, but we need to rule things out as well. So doing our primary assessment, looking for problems associated with airway breathing and circulation, which is the most important thing. Respiratory emergency patients often exhibit signs of distress like altered mental status. They could be unresponsive, and that's all caused by hypoxia, lack of oxygen. Because you can see why now in the alveoli, you're not getting that good oxygen exchange to take place. The heart's not pumping out all that oxygen it needs to pump out to go to the areas it needs to go. So that's why they're hypoxic. Inability to speak easily or in complete sentences, poor chest movement with inhalation and exhalation, increased work of breathing exhibited by accessory muscle use. They might be sitting in that tripod position. Poor skin condition. Are they pale or cyanotic, cool, moist? They're called diaphoretic, cool, sweaty. So if we see any of these signs and our patient is a serious condition, we want to carefully evaluate their ABCs and take necessary action to correct problems. Get your sample, get your OPQRST, or if the patient's not able to ask that or answer that, see if there's like family members or something like caregivers around that can assist you with that as well, just to kind of see what's going on with the patient's present condition. Questions that we can ask them. So when we're doing our OPQRST and sample, when we get into there's like sets of questions that we ask and we know we need to ask with that acronym, but things we can add on top of that are things like, are they having trouble lying flat? Do you need pillows to sleep with at night? That's going to indicate a fluid accumulation in the patient's lungs that worsens when they lie down in that supine position. So a lot of times they'll sleep in their recliner or they'll have like 5 pillows in bed with them. Okay, something's going on. You have some kind of heart issue, usually congestive heart failure. Do you get short of breath when you're active? Have you gained weight over the past several days? That fluid accumulation can increase the body weight in a very short period of time. Did they weigh themselves and gain 4 pounds overnight? That's fluid that needs to come off. Do you have any fluid accumulation in your lower legs? Look at their feet. Can you push in on their feet? Are their feet big? Do they have a cough? If they do, is it productive? What does that mean? Are you coughing up stuff? Okay, what color is that? That can mean different colors can mean different things. Is it clear? Is it pink? Is it frothy? Is it yellow? What are you coughing up? Do they have any pain or heaviness in their chest, their jaw, or their arms? And then are they having any pain when they're breathing? And we can use the pain scale for that too, the severity scale. On a scale of 1 to 10, 1, it's not hard to breathe. 10 is really hard to breathe. Where are you at? So, and then we can ask patients like, okay, it hurts when you breathe. Can you point where it hurts when you breathe? Or it's just all over your chest, like congestion. A lot of respiratory emergency patients take medications for these chronic conditions. Always ask the patient if they're taking their medications as prescribed. Listen for breath sounds with and without a stethoscope. When using a stethoscope, listen at the top of the lungs on the chest, and at the nipple line on the patient's side, and at the bases of the lungs on the patient's back. So usually we listen up here, and then at the nipple line here, and at the base on their back. Are they getting that good air movement when they inhale and when they exhale? Do you hear any wheezing, any crackles? Crackles are like a faint popping noise as the patient inhales. That indicates there's presence of fluid in the alveoli, which again, we know that's a problem. Do we hear any rhonchi? Rhonchi are kind of coarse bubbling or rattling sounds when people are breathing. And some of this stuff you can hear without a stethoscope as well. So positioning the patient, we put these patients in a position of what's called comfort. Um, they're not going to want to lie supine flat on their back. They're probably going to want to sit up or do semi-fowlers, which is kind of half sitting up. So just a position of comfort. Administer oxygen if you think they need it, either by a nasal cannula, a non-rebreather, or if they're really struggling to breathe, or if they're breathing too slow or too fast, we get the bag valve mask out. We hook that to 15 liters to oxygen, liters per minute. Update EMS with the patient's condition. We want to reassure the patient, keep them calm, monitor their condition. I would probably say every 5 minutes doing vitals and doing your initial assessment, and then transferring that care when EMS arrives. So our OPQRST, what's our O? You can say it with me. Onset, right? I'm gonna go back to that. What's our P? Provocations. What's our Q? Quality. R, radiate, region, relief. S, severity. T is our time. Start making flashcards, right? Which of the following is a sign or symptom of MI? All of this. Could be difficulty breathing, could be chest discomfort, could just be nausea, could be lower back pain, could be weakness. Lots of different signs for MIs. And again, the difference between MI and angina is if they sit down, that pain doesn't go away. That's typically an MI. They sit down and relax, the pain starts to kind of go away on its own. Usually that's angina. Just a difference between a blockage, a complete blockage, and a reduced blood flow between those two. What lung sound is musical sound heard on expiration and is consistent with patients having an asthma attack? This one is like, everybody knows it's wheezing. Asthma is consistent with wheezing. All right, I'm gonna stop my screen share. Everybody feeling good about those? Perfect. All right. Moving on to, so that chapter is a little bit shorter and so is the last one, but this one's a little bit longer because everything is altered mental status. We're gonna be going through a lot of stuff. So let me do a little screen share with 15. So 15 is altered mental status, which is a lot. So with this one, we'll talk about altered mental status, diabetic emergencies, stroke, seizures, poisonings. Different types of poisonings: ingested, inhaled, absorbed, injected, and then we'll talk about behavioral emergencies as well. And then, so we'll talk about some causes, medical, psychiatric, and poisoning causes for these. Biggest thing we want to do is make sure the scene is safe when it comes to altered mental status, keeping yourself safe, other responders, accessing the patient, doing appropriate emergency care for them, depending on what is going on. But as a first responder, we're going to encounter patients who present with altered mental status for a variety of different reasons, either medical, psychiatric, or poisoning. So something that we're going to be dealing with. All right. So AMS, it's called. So causes of this. The list is big. Hypoxia, the lack of oxygen, right? That can cause altered mental status. Diabetic emergencies, that also can cause that. People having a stroke, people having a seizure. Why did they have the seizure? Fever or infections, respiratory problems, because we're not getting the oxygen that we need. That one kind of circles back to hypoxia. Environmental exposures, hot or cold, hypothermia, hyperthermia, poisonings and substance abuse. Head injuries and other trauma can also cause this. Psychiatric conditions and cardiac problems. So we're going to talk about most of these on here. So what we want to do is make sure the scene is safe before we enter, get a general impression from the patient on kind of what's going on, what is their normal mental status for that patient. Is their airway open? Are they breathing adequately? What's their circulation, their skin color, temp, condition, what's their respiratory rate, their pulse, all of that fun stuff. And then starting to get into an accurate history of what's going on. Medical history, doing our sample. If we can't get that from the patient, hopefully we can get that from a family member, bystanders, or a caregiver. Want to monitor their ABCs, place the patient with no spine trauma in the recovery position on their side. Consider the need for oxygen to these patients. Hypoxia is a common cause of altered mental status and may be easily corrected by just putting oxygen on them. If oxygen saturation is low, or if the patient shows signs of distress or inadequate breathing, we should be putting that on. Be kind of aggressive about it. Monitor the patient's mental status and vital signs frequently. Treat them as unstable because altered mental status could be lots of different things. We want to start to identify any trends in the patient's condition. If we put oxygen on them, that's an intervention. Let's check back on that. Is that helping? Provide emotional support to the patient and the family. Altered mental status can be frightening for everybody involved, but a patient who, say, has a seizure may lose bladder control or bowel control, which can be embarrassing as well. Patient experiencing a stroke may understand what you're saying, but can't verbally respond, and that can be very frightening for them. So keeping some of that emotional support in mind as well. And then notifying responding EMS of any changes in the patient's condition. It's kind of what we're doing with these patients, trying to figure out why they're having an altered mental status to start with. So some of the reasons: diabetic emergencies. So glucose is the body's fuel. Most cells use insulin to help transfer glucose from the blood to the cells. Diabetes interferes with the body's ability to produce insulin or use it effectively. Some of them just don't produce it. Some of them produce, but not enough. Hyperglycemia, this occurs when there's too much glucose and not enough insulin. Symptoms like altered mental status, that fruity or acetone-like breath, like that juicy fruit breath, warm and dry skin, hungry and thirsty, rapid and weak pulse. We'll get to some of these as we go down as well. Hypoglycemia, this occurs when there's not enough glucose to the too much insulin. Symptoms are the complete opposite. It's rapid onset. They have an altered mental status. They have a rapid pulse, cool, clammy skin. They're going to be very sweaty. They can have a seizure. But differentiating between these two isn't super important at the EMR level because we're going to treat them the same as well. And that's going to be typically with oral glucose if they can put something in by mouth. So glucose is a form of simple sugar that fuels our body. Glucose enters the body through food and drink and is carried to the cells through our bloodstream. But it's large. The glucose molecules are large molecules. They're unable to enter the cells alone, so they need help with that. Insulin is a hormone produced by our pancreas that allows for glucose to enter the cells and act as fuel for our body. Diabetes mellitus, there's type 1 and type 2, but diabetes mellitus, commonly just referred to as diabetes, is a condition that prevents individuals from producing enough insulin. Type 1 diabetes is we can't produce enough. Type 2 diabetes is we're producing it, but it's not using it effectively. So depending on the extent of the patient's diabetic state, they may or may not be able to control it with a balanced diet or oral medication. In more severe cases like type 1 diabetics, they usually have an insulin pump or take injections. But we're going to encounter both of these in the field. A lot of times it's hypoglycemia because it's like sudden onset, where hyperglycemia is more of a chronic, gradual onset. But we don't really have to distinguish between the two because we treat them the same. Causes, so hyperglycemia, hyper, high, meaning hyper, I'm hopped up on stuff, is when blood sugar becomes too high and can cause a few things. It can be from infection, it can be an increased or prolonged stress, it can be failure of the patient to take their insulin or to take a sufficient amount of insulin, failure of the patient to take oral diabetic medications or takes a sufficient amount of those medications, or eating too much food that contains or produces sugar. Hyperglycemia emergency is sometimes called a diabetic coma, also known as DKA, diabetic ketoacidosis. Though the patient is usually not in a coma, but they kind of present that way. These are typically a gradual onset. Excessive hunger, thirst, and urination are the first steps with this. Dehydration, the patient often will appear extremely ill, dehydrated, and they're going to become sicker and weaker over time. If the patient does not receive treatment, eventually they're going to become unresponsive in that DKA and eventually die if we don't do anything about it. So improvement of the patient's condition is also gradual and has to be done in a hospital setting. So they're going to go into the hospital and be put on insulin, and they're going to be slowly brought down. These are the patients that their insulin levels are going to be like 2, 3, 4, 5, 600, which is really high. The highest I've seen is around like 670. And you guys might have glucometers if Jules gives you those, and we'll practice with those. The glucometers that are out in the field, a lot of times if it's over a certain level, usually 500, it'll just say high. And if it's under a certain level, like some of them are set at 30, some of them are set at 50, it'll just say low. Then you know that they are over 500 if it says high. It just depends on what your monitor says. But some signs and symptoms for hyper, altered mental status, sweet, fruity, or acetone-like breath, flushed, warm, dry skin. They're going to be hungry and thirsty. They're going to have a rapid, weak pulse. They're going to have like an intoxicated appearance, like they're drunk, frequent urination, and they could have blurry vision with it. Hypo or low, hypoglycemia is low blood sugar. So this is where the monitor would say low. Usually you're dealing with patients like in the 17, 27, it depends on how the patient presents. But hypoglycemia is when blood sugar becomes too low. And some causes for that are taking too much insulin, not taking enough sugar or too little glucose, taking too much oral glucose medication, skipping meals, vomiting. So if they've been ill lately, so things that we can ask them, strenuous exercise, physical stress from extreme heat or cold, and emotional stress, weddings, funerals, bad news, that type of thing. We're going to get these calls frequently for hypoglycemia. We get them all the time up here in Ely. These are sudden onset, which is why people call. So things we can ask: have they eaten today? Have they taken their medication? Have you had any recent problems with medication? We've had people that their pumps break and just download them with insulin, um, just throws their sugar level off. Have they been sick or under any stress? These are all reasons that, potentially they could be having issues with this. Check around for clues. If you don't know they're diabetic, we can look for medical alert jewelry. We can look in their fridge. Usually the insulin is in the fridge because it needs to be refrigerated. So things like that. So with this, the signs and symptoms that you'll see: rapid onset, intoxicated appearance, very similar to the other one, rapid pulse rate. These guys are not going to be dry. They're going to be cool, clammy. They're going to be really sweaty. They're going to be hungry and thirsty. They could have a headache and go into a seizure as well. So emergency care, we want to make sure we have an open airway, make sure they have adequate breathing, adequate circulation. We can position these patients either sitting up or in that recovery position on their side. High flow oxygen is good for these patients. If local protocol allows and the patient is conscious and able to swallow, we can give them sugar by mouth, pop, orange juice, milk, something to drink that has sugar and add sugar packets to it. If you carry glucose, we can give them oral glucose as well. We want to monitor their mental status and vital signs as we give that stuff. If they're unable to swallow, we do not give them anything by mouth ever. But if they're able to swallow, we can do that. And once they start coming around a little bit more, I've been known to make people sandwiches at their house to get more of those, the milk and orange juice and all that stuff we're giving them to with simple sugars. We want to give them more substantial stuff too as we go. So provide emotional support and then report any changes to the EMS crew coming in. Oral glucose. This is if your local protocol allows for you to do this. If somebody's having a stroke, it can have a harmful effect on them. So we want to make sure we rule out stroke, and we'll talk about how to do that coming up here. But determining whether the patient's hyperglycemic or hypoglycemic, we don't have a monitor, we don't know. This is not going to hurt them either way. So we can ensure that they're awake and can swallow. Obviously, never give a patient who cannot control their airway anything to eat or drink because they can aspirate on that, which is more complicated. We can actually kill people doing that. They aspirate it. So 2 ways to administer the sugar to the patient. We can dissolve sugar in water, juice, or have the patient drink it, like I said. Or we can squeeze these commercially prepared glucose packets like the Glucose 15 on here. This is 15 grams. They come in bigger tubes as well. But one tube is the adult dose. If you have a pediatric patient that you're dealing with, it's half a tube. But we can either have them squeeze it in their cheek or put it on a tongue depressor and put it between their cheek and their gum so it can start to kind of dissolve into there and get into their system. And then notify the EMTs that you're administering sugar as well. So that would be what we do for diabetic patients. People having a stroke. So classic sign, this guy, stroke is caused by an interruption of brain's blood supply, either by a clot or a bleed. So some signs and symptoms, and we'll get to more of these of a stroke: altered mental status, inability to communicate, or an impairment of one part of the body or one side of the body. Temporary signs of a stroke may indicate what's called a TIA, or transient ischemic attack. They call those mini strokes. And if people are having those, they kind of go away on their own, but they also will lead to a bigger stroke eventually. There are 2 different types of strokes. Like I said, either by a clot or bleed. There's the hemorrhagic stroke or ischemic stroke. I mean, it's hard to differentiate that in the field. You kind of need a CAT scan for that. But the most important thing for us is to verify when it started. So getting that initial onset of time or their last known well time is super important for some of the medications they're going to push on these patients. So writing down the time those symptoms started. So like the heart, the brain needs a constant supply of oxygen to function. Any interruption in that blood supply results in a cerebral vascular accident, what's called CVA, or a brain attack. That's actually what a stroke is called, is a CVA. Commonly known as a stroke. The American Heart or the American Stroke Association refers this as a brain attack. So again, the two different types of strokes are ischemic stroke. These are caused by a blockage of blood flow to the brain by a clot. This is the most common type of stroke. So there's just a blood clot in there, and they're not getting any oxygen to that part of the brain. The other one is called a hemorrhagic stroke, hemo meaning blood, right? So you can see where that's going. This is caused by a broken blood vessel in the brain. Stroke is the third leading cause of death in the US and the leading cause of disability in people. Strokes can occur at any age, but most commonly occurs in those 65 years or older. Sometimes patients experience signs and symptoms of strokes that only last a short period of time. Those are those transient ischemic attacks, those TIAs. These episodes are referred to as that or mini strokes. And these are just warning signs that an impending stroke is going to occur in the future. So those patients should be brought in and checked out. Signs and symptoms of stroke, you have altered mental status. Mental status can range from a change in personality to seizures to being just them being unresponsive. So asking family members or bystanders as well, like what's their normal mental status? Is this normal for them? Because they maybe haven't had a stroke in the past. So just seeing what's different. Inability to communicate. Patient may either fail to speak normally or fail to understand what others are saying. Impairment in one part or side of the body. Generally, a stroke occurs in the part of the brain opposite from the impairment. So when the patient is having a left-sided stroke, it is impairing the right side of their body and the opposite. So when handling the patient, ensure the paralyzed extremities also don't get injured or not flailing them around. They could have an elevated blood pressure. About half of all stroke patients experience an elevated blood pressure or hypertension. A combination of a decreased mental status, increased blood pressure, a slow pulse, and rapid or irregular breathing is a sign of a major stroke. So be prepared for that patient to experience maybe going into a seizure. Finding out exactly when the patient's signs and symptoms begin, because there's a limited amount of time when they can be treated for this with the medication that they give them. So again, the combination of a decreased mental status, increased blood pressure, a slower pulse rate, or rapid and irregular breathing, those are all major stroke signs. So assessment for strokes, there's two different things that we can use. There's what's called the Cincinnati Pre-Hospital Stroke Scale, and this is going to be for facial droop, arm drift, and slurred speech. So when it comes to facial droop, we're going to assess, we're going to ask the patient to smile, and if they got a nice smile and it's symmetrical, great. An abnormal finding would be asymmetry or drooping on one side of the face. The next thing that we're going to do is arm drift. So to assess for arm drift, we're going to ask the patient to close their eyes, hold their arms directly out in front of them, palms down, have the patient hold their arms in the position for about 30 seconds and watch to see if it drifts away from them or downward from the original position. Ensure the patients keep their eyes closed so they can't cheat on you for this. And then the last part of this is slurred speech. So a lot of times we'll ask them to repeat back to us. You can't teach an old dog new tricks. And if they're just staring at you or slurring their words while they're repeating, that's the abnormal finding for that, or their inability to speak at all. The new one that's out there, and I like this one, this is called BFAST. And so this one is a stroke assessment pathway. The one that's the pre-hospital Cincinnati stroke scale I just showed you, if they have any one of those signs and symptoms, they're having a 76% chance likely that they're having a stroke. This one, BFAST positive, if they hit any two of these. So the first one is balance. And the reason I like this is because this is finding people that are having posterior strokes in the back of their head, which is all based on balance. They have a sudden loss of balance and coordination. That's unexplained vertigo, unsteadiness, unexplained falls. Have they had any of that? Okay, that is a sign of a stroke. Their eyes, sudden change in visual fields, loss or blurred vision in one or both eyes, looking at their pupils as well. There's one big, one small. And then we get back into the Cincinnati stroke scale. Facial droop, ask them to smile. Arms, we're going to have to do the arm drift. And then speech, sudden confusion, trouble speaking, and then the time, when did it first start? Onset less than 24 hours ago, when did it first start? So I'm kind of liking, this is the method we use right now to find these posterior strokes with these first two, the balance and the eyes. So that's a good one to use. So emergency care with this, just making sure they have an open airway, adequate breathing and circulation, positioning the patient either in the recovery position or sitting up. Consider oxygen if their O2 sats below 95% or local protocol. A lot of them are 94 now. Current science does indicate it's possible to administer too much oxygen to a stroke patient. If you don't have a pulse ox, so the patient appears hypoxic, we're going to administer per protocol. Monitor their airway, ABCs. These patients obviously are unstable, so monitoring them every 5 minutes, providing emotional support for them. And we're not going to give any of these patients anything by mouth. They can aspirate. Now they can't protect their airway. So nothing by mouth for these patients. The next slide is just the stroke algorithm, which is kind of the BFAST model. Identifying signs and symptoms, so doing the Cincinnati Pre-Hospital Stroke Scale or BFAST, and then kind of our arrival times that we need them under, supporting ABCs, just doing our immediate assessment, getting the time, trying to get them to CT as fast as we can to see if it's hemorrhagic or ischemic and when the onset first was. All right. Seizures. So a seizure is a sudden change in behavior or movement caused by an irregular electrical activity in the brain. It can last from a few seconds to several minutes. Symptoms can range from a twitch of part of the body to the entire body muscle contractions, which would be like the tonic-clonic seizure. They're very strenuous on the body, and many patients are extremely sleepy afterwards. They say it's the equivalent of like running a marathon. They're usually not life-threatening, but they can indicate serious underlying problems, what's going on with our patients. So like altered mental status, seizures have a ton of causes. Chronic medical conditions, epilepsy, hypoglycemia, poisonings, substance abuse, strokes, fevers. Fevers would be like the febrile seizures in the kids, like 4 and under. Their temperature spikes and they go into febrile seizure. Infections, head injuries, brain tumors, hypoxia, and then complications of pregnancy, which we'll get to when we do OBGYN. This would be like eclampsia, preeclampsia. So most commonly, we're going to be responding to a generalized tonic-clonic seizure. This is formally called a grand mal seizure. The seizures affect the entire body and have 4 phases. So they have an aura phase. This one, the patient becomes aware that they're going to have a seizure. Not everybody has that, but a lot of people do. It may be described as an aura or unusual smell, taste, or a visual image. Then they have the tonic phase. This one, the patient becomes unresponsive and collapses to the ground. Muscles contract and the body becomes stiff. Sputum it can look kind of like foam, may be forced from the mouth. The patient may briefly stop breathing. The clonic phase with this is the muscles, the alteration between the muscle contractions and relaxation. The patient becomes incontinent typically, so be alert for blood in the mouth, biting the tongue or cheeks. They're probably going to have a loss of bladder or bowel movement. And then they go into their final phase, which is the postictal state. Patient gradually regains responsiveness. They're going to be super tired. They're going to be confused. They can be combative. So afterwards, they're going to become more and more aware of their surroundings and what was happening. So taking your standard precautions, remain calm. Seizures can be very scary for people to watch. So we want to wait till the end of the seizure, prevent any further injury of the patient by moving objects out of the way. If we can't move objects, we should be putting padding around them so they're not hurting themselves, behind their head. If they have glasses on, we can take the glasses off. Don't force anything into the patient's mouth. Muscle contractions can be very strong, and the patient may break the object or their teeth. Now we're dealing with airway. Don't attempt to restrain the patient because injury to that can result as well. So just let them have their seizure, pat around them, and we'll see what happens at the end. Usually they start coming out of it. I always note the time down, like how long did the seizure last, because the doctors are going to want to know that. Was it 10 minutes? Was it 1 minute? Was it 10 seconds? Was it 2 minutes? About how long was the seizure? Things that we can ask to if we're not quite on scene yet, if people are watching it. For emergency care, monitor the patient's airway and breathing when this is all done after the seizure. They're in that postictal state. Place them in the recovery position on their side, left or right, doesn't matter anymore. Apply high flow oxygen by a non-rebreather mask or a bag valve mask because they are lacking oxygen in their body right now. Provide emotional support to the family and the patient. It is a little bit scary. Tell EMS responders as much as you can about the seizure, the details, so the activity of it, the length of it, the number of seizures. Did they have two in a row? Was there any trauma involved, either before or after? Did they fall and hit their head? Were they incontinent? That's pretty common. So we can take steps to maintain privacy of the patient, maybe put a blanket over them, something like that as well. Um, So some patients may experience a continuous seizure lasting several minutes or have back-to-back seizures with no regaining of consciousness between them. That indicates a life-threatening emergency, and this is called status epilepticus. Complications include hypoxia or lack of oxygen, hyperthermia, their body's heating up too much, or heart problems. So monitoring their airway and breathing, putting them in that recovery position when they're done, try to getting high flow oxygen on them, maybe when they're even having a seizure, kind of doing that blow by oxygen if we can. Um, Providing emotional support to the family and the patient, and notifying EMS that you're suspecting status epilepticus, because you might want to consider ALS. There's some medications they can give them. There's also a magnet some people have that the family members will have that can stop seizures. And there's also a nasal spray now that is mostly for pediatric patients that can stop seizures as well. That's kind of out there. So things to know. All right, poisonings. So this is a general kind of, these are the four routes. You have injection, and then we'll talk about each one of these again. So injection is poisons entering the body through a puncture or break in the skin. So bites, stings from animals, injection of chemicals, of drugs with a needle. Ingestion, this is poisons enter the body through mouth and enter into the digestive tract. Aspirin and alcohol are the most frequent agents for this. Other medications, cleaning chemicals, lead paint, tainted foods. Inhalation, this is poisons enter the body through the respiratory tract. Poisons also will include for like fine mists, gases like carbon monoxide. That's the most commonly inhaled poison. The carbon monoxide is a result of incomplete combustion and can be present without undefinable smoke. Cyanide can result in the burning of certain plastics, people mixing chemicals. Absorption, this is poisoning enters through the intact skin. So poisonous plants like poison ivy, pesticides, herbicides, cleaning products, industrial chemicals, that type of thing. People can have altered mental status with this. We want to get a history. What substance is involved if they know, how much was involved. So if the patient drank a liquid, how full was the container, how much is missing, when did the exposure occur, what was the time of the ingestion, what's the patient's weight. These are things that poison control is going to want to know. What's the patient's weight, and paramedics will want to know as well, so they know what to give them and how to treat them. What has been done to treat the patient this far? Has there anything been given to them prior to our arrival? Does the patient have any underlying conditions that may complicate or make the poisoning worse or more dangerous? So we can assess the ABCs, place the patient in the recovery position, high flow oxygen to the patient by non-rebreather or bag valve mask, identify the poison, look around at the scene for clues, empty bottles or containers, look at the pill bottles. If there's a pill bottle, is it like, what's the date on the pill bottle? How much is supposed to be in there? Things we can maybe figure out. If you're in an industrial setting, they have these things called MSDS, which actually they've taken off a few years ago. Now it's just SDS sheets. These are called safety data sheets. These will be in a yellow binder with red lettering around any chemicals, usually in the maintenance area. And they tell you what these chemicals, what's in them, the manufacturer, the health concerns, what to do for first aid. All of that stuff is in these safety data sheets for the substance that's involved. We can contact poison control. You can do that through dispatch or call their number, 1-800-222-1222. A lot of people have stickers in places. Providing emotional support to the patient, and then notifying EMS of what substance is involved so they can start planning that. So that's a general, like, what we do for poisons. When we get down into each poison, so ingested poisons, while on scene, look for clues to identify the type of quantity of poisons ingested, empty or spilled bottle or containers, overturned plants, especially if the patient's a child, drug paraphernalia. Signs and symptoms of ingested poisons, altered mental status, if they have a history of it, odd breath odors, excessive salivation, tearing or sweating, and abdominal pain, as well as nausea, vomiting, and diarrhea, burns around the mouth or the nose, dilated or constricted pupils, seizures, and vision problems are all some signs and symptoms you'll see with ingested poisons. And so these are all the same for the most part. Monitor ABCs, position them on their side, high flow oxygen, identify the poison, contact poison control, provide emotional support, notify, respond to EMS, and avoid administering medications that are going to induce vomiting. We don't carry syrup of Ipecac anymore. If that was a thing when you guys did this before, it's more activated charcoal at this point for our level of care, if that's available and that's something you carry. We don't even carry that on the ambulance here, but that is a thing that you can do, is activated charcoal for some of these. It just binds with that chemical. We just don't want to induce vomiting. Alcohol emergencies. So alcohol and drugs are also considered ingested poisons when they're misused. Drug abuse is the self-administration of one or more drugs in a way that differs from the approved medical or social practice of that drug. An overdose is an emergency that involves poisoning by drugs or alcohol. This can be the result of a long-term drug abuse, just a dose miscalculation, confusion, use of more than one drug at the same time, called polypharmacia, or suicide attempt. And no one is exempt from the potential for drug or alcohol abuse, regardless of their race, their religion, socioeconomic status. It is across the board. Anybody can have a problem with this. Withdrawal, alcohol withdrawal is terrible. This refers to the effects of the body that occurs after a period of abstinence from the drug or alcohol to which the body has become accustomed to. Several medical problems can result from drug or alcohol withdrawal. Respiratory problems is a big one, internal injury, seizures, hypothermia, hyperthermia, cardiac arrest. We've seen kind of all of that with alcohol withdrawal. Various drugs can also cause changes in respiratory, circulatory, and nervous systems. Stimulants increase the body's process, while depressants decrease the body's process. Other drugs may cause a variety of sensory or behavioral altering effects as well. So signs and symptoms of drug or alcohol emergencies: they have an altered mental status, respiratory problems, abnormal pulse, nausea and vomiting, seizures. They have an odor on their breath. You're going to see a lot of vomiting with alcohol withdrawal. Swaying or unsteadiness, slurred speech, flushed face, violent, disruptive, or erratic behavior. So remember, scene safety, and then self-injury. You're also going to see like the tremors in some patients as well. So again, monitor their ABCs if we're suspecting this. Again, scene safety, get law enforcement involved if needed. Place patient in that recovery position to help avoid aspiration, so fluid can come out if they vomit. High flow oxygen, monitor their vital signs and mental status. Mental status, again, is our AVPU, alert, voice, pain, unresponsive. Maintain the patient's body temperature. Some drugs induce hyperthermia, so if they start getting warm, treat them as hypothermic, or try to cool them down. Take steps then to prevent shock, which is the opposite, covering with a blanket, putting on oxygen. Providing emotional support to the patient, and then immediately notifying responding EMS of what's going on with the patient or if there's any changes with that. All right, inhaled poisons. So although some inhaled poisons have an odor, some don't. We're never going to rely on smell to make that safety decision. If you start smelling stuff as you go in, you obviously didn't have COVID like I did. So signs of inhaled poisons include soot, burns, or singed hair around the mouth or nose, breathing difficulty, and altered mental status. Carbon monoxide is a commonly found gas. It causes headaches, altered mental status, and eventually death if left untreated. Key treatments for carbon monoxide poisonings include staying safe. If you have multiple patients in that same area, that same house, we're not going in there. Get the fire department out there. They can go in with their SCBAs on because we want to remove that patient from the source and administer high flow oxygen. Take safety as your first concern. Many inhaled poisons are colorless and odorless, so their presence is difficult to detect. When a patient is down for an unidentifiable reason, consider looking for clues before you rush in there. Inhaled poisons often cause airway and breathing problems, so maintaining airway and breathing adequacy for the patient is important with that. So if we have to get the bag valve mask out and do that, would be appropriate to be very aggressive with oxygen. So inhaled poisons, some signs and symptoms: soot, burns or singed hair around the mouth and the nose, breathing difficulty, altered mental status, chest pain, dizziness, cough, hoarseness, or burning in the throat because they're obviously inhaling it. Cyanosis, lack of oxygen, starting there, hypoxic, headaches, seizures, and they can be unresponsive as well. Carbon monoxide, like I said earlier, it can be lethal. It's a lethal gas. It's colorless, it's odorless. Common sources are kerosene heaters, gas water heaters, car exhaust, smoke inhalation. When at a scene where multiple people are complaining of the same symptoms, always consider this. This is particularly common with carbon monoxide poisoning. It can affect animals as well, so observe pets for the same illness, signs, and symptoms. People saying their dog's getting very sleepy. Oh, here we go. So signs and symptoms with carbon monoxide: headache, agitation, nausea or vomiting, confusion, diminished vision or blindness, difficulty breathing, rapid pulse, dizziness, faintness, unresponsiveness. They can have a seizure, and they're going to have a cherry red color to their skin if they've been exposed to it for a long period of time. So again, with this, removing the patient when it's safe to do so, I would say fire department with their SCBAs, they can start opening the windows and doors. And we can try that from the outside, but we can open the door at least. Monitor ABCs, put them in their recovery position, apply oxygen. These patients, if they're really bad, they're usually transported to a specialty care center with a hyperbaric chamber to push oxygen. And the closest one for us typically is the cities that they'll be transported to. So providing oxygen, monitor vital signs of mental status, providing emotional support, and then notifying EMS. So you can see where this is kind of, a lot of this is the same. Absorbed poisons. So again, these are ones that are on our skin, often easy to see. Care should be taken not to transfer that poison to you. So making sure that you have all your PPE on as well. Signs of absorbed poison include liquid or powder on the skin, burns, itching, or irritation. So some elements when treating absorbed poisons: making sure you're carefully removing the contaminated clothing. We're going to remove excessive poison. If it's dry, we brush it off, and then we're going to flood it with lots and lots and lots and lots of water. Copious amounts of water, they say. Absorbed poisons are usually the easiest to identify because the substance is often on the patient or it's a spilled container at the scene. So also look for the possibility of poisonous plants if the containers are not present. Those oil-based poisons can easily transfer from them to you, especially if you're really poisonous to like poison oak or poison ivy. The oils can get everywhere, and people can be so allergic that just breathing it in can cause a problem. If the poisons involve a hazardous material, we're going to talk more about that in a different chapter, and I'll show you guys the emergency response guidebook. That's that little orange guidebook that we can look at to see what to do. So assessment for absorbed poisons, some of the signs and symptoms: liquid or powders present, burns, itching or irritation, redness, rash, or blisters, and excessive salivation, tearing. So we want to remove the patient from the source. Again, if it's a wet substance, lots and lots of water. If it's a dry substance, we want to make sure we brush all that off first, and then lots and lots of water. Remove the patient from that source, monitor ABCs, position them in a position of comfort or the recovery position, high flow oxygen, remove the poisonous substance, monitor their vital signs and their mental status, because they could go from alert to verbal, or they could go from verbal to alert, depending on what's happening. Provide emotional support and notify EMS about the patient's condition. So again, dry poisons, remove clothing, brush it off. Wet poisons, remove clothing, blot, and rinse. And just lots and lots and lots and lots of water with these. Get the garden hose out or put them in the shower. If it's in their eyes, use those wash stations. Just put their head in there. Injected poisons. This is a poison that may be a drug that enters the body by way of hypodermic needle or animal or insect bite. Anaphylaxis is often caused by injected poisons, especially with bees and stuff like that. So needles, bites, stings, allergic reactions. When assessing these patients, remain alert for signs of an allergic reaction. It's not uncommon with the bites and stings. So the leading cause of death. So there's not much to that one. So we know what to do for anaphylaxis. If we don't, we'll be talking about that. Behavioral emergencies. So this is any situation in which a patient's behavior is unacceptable or intolerable to the patient, the family, or the community. These patients may appear agitated and display bizarre thinking like hallucinations or paranoia. They may be dangerous to themselves as a result of self-destruction, behavior, even suicidal attempts or suicidal ideation, they say. They may also be in danger to others, including us, as a result of threatening behavior, violence, or use of weapons. So scene safety, your safety comes first, right? Be alert for changes in their mannerisms and their behaviors. Factors that may influence their behavior are situational stresses, like a person's reaction to death of a loved one or being involved in an incident where a lot of people are injured. It could be a medical illness like diabetic patients whose blood sugars are low. Could be a psychiatric problem like schizophrenia or bipolar, alcohol or drug use, and noncompliance. Patients who are noncompliant with medications, particularly psychiatric patients who are not taking their antipsychotic medication. Physical conditions. So lots of reasons people can have these, right? Behavioral issues. Physical conditions, hypoglycemia, hypoxia, lack of oxygen, shock. They could have head trauma, mind-altering substances. They could have a psychiatric condition, and then excessive heat and cold, hypothermia, hyperthermia. Brain infections like meningitis, seizure disorders, poisonings, overdoses, and if somebody's in withdrawal, alcohol or drug withdrawal. So signs and symptoms to look out for: altered mental status or AMS, altered speech, poor appearance or hygiene, agitated stance or gait, that's their walk, variations in their mood, perception, or attention, violent or aggressive behavior. When it comes for assessment for suicide ideation stuff, to assess for risk for this, some questions that we can ask. Does the patient have any weapons on their self or with them? We can also ask the police to check. I know some ERs that we go to, like I was just at Hennepin County the other day, and they actually scanned the patients in when we brought them in for weapons. There was a cop standing there with a wand, like a metal wand, and he scanned our patient before we could even go through the door of the ER. And they did that to everybody coming in. Has the patient been depressed lately? Has the patient had a recent major life event like a divorce, loss of a loved one, they lose their job, they get diagnosed with a terminal illness? Has the patient done anything that would indicate the possibility risk of suicide or violence against themselves or others? How does the patient feel? Is the patient thinking about hurting themselves or hurting somebody else? Is the patient a threat to themselves or others? Is there a medical problem going on here? Is this a trauma that we're dealing with? Is the patient being treated for a behavioral problem? So there's a lot of different things that we can ask about when it comes to suicidal ideations or suicide risk. So suicide stats as of 2004, I know this is 20 years old, but in ages 10 to 14, it was 1.3 per 100,000. And it just gets more as you get older. 65 and older is 14.3 per 100,000 people. So it's that age bracket that is affected the most. The national average is 10.9 in 100,000 in the general population. So dealing with behavioral emergency patients can be a trying situation for you as a first responder and the patient themselves. In addition to identifying and correcting any life-threatening problems, we should focus our efforts on keeping the patient calm, and then reviewing some of the questions that we can ask them. But a comfortable distance, encouraging them to talk, avoid quick movements, respond honestly to them, restate that you're there to help, inform them that what you're doing as you're going through stuff, keeping them calm, protecting yourself and them. Don't threaten, challenge, or argue or play along. Involve family or friends if it's appropriate. Remain with the patient. Avoid physical contact. Keep that bubble. Within 3 feet is kind of like the personal distance. Kind of stay outside of that. Avoid that physical contact. Maintain eye contact with them. Avoid threatening postures like crossing your arms and standing over them. Hopefully, we can talk the patient into cooperating. When treating these patients with behavioral emergencies, remember the key elements of assessing the safety. Want to make sure we're kind of de-escalating things, not leaving that patient alone. We're not going to belittle or threaten them. We're going to be calm and reassuring. Trying to lower distressing stimuli. So if there's a TV on, shut that off. Radio's going, shut that off. You have your radio blaring, turn it down. Don't turn it off, just turn it down so you can still get out if you need to. Avoid restraints unless it's necessary. Treat them with respect and call additional help if you need to. Like if you just need to leave and get law enforcement involved, sometimes that happens as well. So if it's a scene safety issue and it's your safety involved, it's not abandoning your patient. We just need to document the hell out of it. So ensure scene safety, try to establish a rapport with the patient, listen to what they're saying, avoid threatening actions, statements, or questions, try to take steps to keep them calm. Don't leave the patient alone unless the situation becomes unsafe. Consider law enforcement. We can assist with restraints if that's necessary. We try to do that as a last resort. Monitor vital signs and mental status. Treat injuries. Provide emotional support. Notify EMS of any changes. All right, so the main source of fuel for the body's cells is glucose, right? All of the following are common causes of hyperglycemia, except, sorry, that's my dog, not taking enough. And then an interruption of the blood supply to the brain is called stroke. All right, I'm going to stop screen share because my dog is barking. I'm going to hit pause on here for the recording. Calm down. And we have chapter 16. Get rid of that one. Let's see. That big. All right, so this one is medical emergencies, which we've talked a lot about already, the strokes and the cardiac and all of that, respiratory. This one is going to be like general medical complaints, and we'll go over anaphylaxis, abdominal emergencies, and renal emergencies. So a medical emergency is an emergency in which trauma is not the cause of a patient's condition. We're dealing specifically with just medical. We're going to come across patients with medical emergencies who have specific complaints like my stomach hurts, and the ones that have non-specific complaints like I don't feel well. That later complaint, like I don't feel well, is it's a hard one, right? It's hard to narrow things down. Like, well, what doesn't feel well? So as a first responder, our first responsibility is scene safety, followed by patient assessment and appropriate emergency care. So general medical complaints. Patients with medical complaints, these are hard because we're pulling out the sample and the OPQRST and trying to ask a bunch of questions on what's going on. But typically for you guys, you're going to know with your clients kind of what's going on already and what their complaints generally are. This is going to be a little bit more difficult if you get on like a first responder agency where you just show up at somebody's house, you have no idea who they are and what's going on. So be a little bit less challenging. Where trauma is easy, broken leg, splinted kind of thing, but medical is a lot of questions that we need to ask. So when a medical patient has a non-specific complaint, like I don't feel well, it presents a challenge. An appropriate assessment is going to assist us in kind of guiding what's going on. So patients with vague complaints kind of can be a little bit frightening and concerning about their health and what's causing that present illness. So we want to remain calm, treat the patient in a professional manner, Be truthful, empathetic with our patients, and ensure them that we're going to try to do everything possible to help them. We just got to figure out what's going on with them. Least of all, at least try to get them to go to the hospital and get checked out, because some older people don't want to do that. So always begin with making sure the scene's safe, putting your PPE on. We're going to monitor airway, breathing, circulation. We're going to have them sit in a position of comfort. Consider the use of O2 if they're showing signs of like shortness of breath, respiratory distress. Monitor changes in their condition frequently. We're going to treat these as unstable patients if we're not sure what's going on. Provide emotional support, and then notify EMS of any changes. So in general, if we have general complaints like I don't feel well, we're going to start trying to figure out what's going on with them with our sample, OPQRST, getting their vital signs, that type of thing. Anaphylaxis. This is the immune system uses antibodies. Sorry, my cat's just throwing stuff at him. He's scratching everywhere. The immune system uses antibodies to identify and attack foreign substances inside the body. Typically, a predictable series of events occurs as a result of that response. Some patients have an exaggerated response to an allergen, and this is a form of an allergic reaction. It can be mild or severe, like anaphylaxis. So an allergen is any substance that causes an abnormal immune response or hypersensitivity. When first exposed to an allergen, a person isn't going to have an allergic reaction. After the initial contact with that allergen, we're going to develop antibodies against that substance. And every time a person then comes into contact with an allergen for which then we have antibodies for, those antibodies are going to attack that allergen, causing a chemical like our histamines and leukotrienes to be released into our bloodstream. And these chemicals cause blood vessels to dilate and bronchioles to constrict. So it's going to dilate our blood vessels, which is where like the hives and the itching and all that comes from. And it's going to constrict our bronchioles, which is where the difficulty breathing comes in. Some patients will experience allergic reaction or exaggerated immune response. Other patients have a more severe, potentially life-threatening reaction called anaphylaxis or anaphylactic shock. Anaphylaxis may occur within seconds or minutes after exposure when signs and symptoms include respiratory distress or suspected shock. So wheezing, their throat's closing up, their tongue's getting big, it's harder to breathe. That's an anaphylactic reaction. Common causes of the allergic reactions or anaphylaxis in order of frequency are medications. Allergies to antibiotics like penicillin are pretty common. Foods, nuts, dairy products, and seafood. You have a slower onset with signs and symptoms, with the exception of peanuts. That's pretty rapid. Insects, bees, wasps, yellow jackets, and hornets. Those are usually our rapid and severe reaction. Plants like poison ivy, poison oak, poison sumac. This occurs from the exposure to the plant pollen and the plant oils. And those reactions are usually localized to areas exposed. I have dealt with a couple patients where they're really allergic to those, even the oil, and they breathe it in. They're having difficulty breathing. So that is a thing. And some other ones like latex, dust, chemicals, soaps, makeup. People can be allergic to just about anything. So anaphylaxis in particular, anaphylactic shock, the thing we're really nervous about. Respiratory wise, they're gonna be in respiratory distress. They're gonna be wheezing. Their skin is gonna be pale red, cyanotic, so that bluish color. They're gonna be itchy, have hives, swelling of the eyes, mouth, and tongue. This is where we're start to get a little nervous. So respiratory wise, they're not doing good. Skin is looking kind of junky. Nervous system, they're gonna have an altered mental status potentially. Cardiovascular wise, they're gonna have a rapid pulse and a low blood pressure because vasodilation, right? And bronchoconstriction. GI wise, you're going to have a little nausea, maybe be vomiting. So we want to monitor ABCs, position them in a position of comfort, high flow oxygen by non-rebreather, a bag valve mask as needed. We're going to remove that allergen. So if it's like a bee sting, we're going to scrape it off with a card. Whatever allergens around them, but it's peanuts, we move those out of there. We get their EpiPen ready. If you're not sure how to use those, we'll practice with those at some point. Because these are the reasons we're going to use it on somebody. Ask the patient if they have one. A lot of people that have anaphylactic reactions also have an EpiPen. They usually come in a 2-pack. We want to monitor their vital signs and mental status frequently before and after we give these. So epinephrine auto-injectors, patients with severe history of the allergic reactions or anaphylactic are going to be prescribed these and carry them typically. Epinephrine is a hormone produced by the body. When we use it as a medication, it reverses the effects of the stimulated immune system. It constricts blood vessels and dilates the respiratory passage. So it does the complete opposite of what the allergen did, which is why it works quickly and helps to relieve that life-threatening signs and symptoms of this. So in most cases, the patients will have administered one maybe before we get there. If signs and symptoms are not relieved within 10 minutes, they're going to need another one. The signs and symptoms after 10 or 15 minutes will start coming back, which is usually why they're coming a 2-pack. So if they get an EpiPen, they're going to the hospital essentially, and we're calling 911. So with these, we want to open the cap. There's a little, and this is an old picture, but the new ones are kind of the adult ones are yellow, and the Epi Juniors are green, but they can look like this still as well with just the regular epinephrine auto-injector brand. We want to remove the cap off the end here. They're looking at the expiration date, making sure it's colorless or clear. We're going to put our fist around it, and we're going to stick it into their thigh at a 90-degree angle, and we're going to hold it there for 10 seconds. So don't touch either end because the needle does come out of one end. So if you're not sure, hold it in the middle. Inject it into their thigh for 10 seconds, and then we're going to remove it, put it in a sharps container, and then massage their thigh for about 10 seconds so it can kind of get that through their system. And then take steps to ensure that it's nobody's going to get stuck by it as well. When you give these, expect some side effects. So they're going to have an increased heart rate because you're giving them a bunch of adrenaline. Pale skin, they're going to be dizzy. They could have chest pain with this, headache, nausea and vomiting, and they're going to be excitable or anxious because we just dosed them with 0.3 milligrams of epinephrine. So, all right, abdominal emergencies, and we'll practice with those when you guys meet up with Jules. We can get those out and practice with them. Abdominal emergencies. So abdominal emergencies may result from digestive tract organs like the esophagus, the stomach, the intestines, accessory organs like our spleen, our liver, our pancreas, our gallbladder, or urinary tract organs like our kidneys and urinary or bladder, or it could be reproductive. So treating life threats is always more important than determining specific abdominal problems. If they're having trouble breathing, put oxygen on them, right? Things that we can treat as we go, because the abdominal area is huge and we never really know what's going on in there unless we can pinpoint stuff exactly. So signs of abdominal problems, we'll get to that in a second. But acute abdomen, when a patient experiences acute onset or like happening right away, that's acute, where chronic is happening over a long period of time. So acute onset of abdominal pain, this is just typically referred to as acute abdomen. Complaints can be from various organs and vessels in the abdominal cavity. A lot of times people will be in that fetal position. It helps reduce the tension on the abdominal muscles, which reduces pain, and is usually the most comfortable position for people. So when assessing the abdominal area, we want to inspect and palpate for abnormal signs. So we can look, listen, and feel, but we want to feel the abdominal area to see if it's distended, like an overinflated balloon. If there's swelling or a deformity, bruising, any discoloration that you see. Is it rigid or hard to the touch? That might mean internal bleeding. Is there pain when you palpate? Is the pain worse when you press in or when you release it? So like if somebody's having an appendicitis or an appendix attack, if you push down on that, it's going to be fine. When you release it, it's going to hurt in that right lower quadrant. So just little things like that is good to know. If the patient complains of discomfort in a specific quadrant or region, inspect and palpate that area last. Because if we push that first, then everything's going to hurt and it's not going to tell us much. So abdominal area, lots of stuff going on in there. So when assessing an abdominal emergency, patients usually have some kind of complaints like the pain. Okay, you have pain. Is it local? Can you point at it? Is it diffuse? Is it just all over? Is it crampy? Like, what does it feel like? Tenderness, again, local or diffuse. That just means, is it like, can you point at it, or is it just in general all over the place? Rigid, tense, or distended abdominal area when we palpate. Anxiety, they have a reluctance to move because it feels better in that fetal position. Loss of appetite. You're not going to want to eat much if your stomach isn't feeling good. Shock, that can be part of internal bleeding. Their abdominal area is like rigid or hard. They may have like a GI bleed or something like that going on. Nausea, vomiting, diarrhea. What color is it? I know this is a gross topic, but like, what is it? Bright red when you vomit or poop, right? Or is it dark and terry like coffee grounds? Like, I'm looking for that stuff. Like, okay, you vomited, let me see it. What color is it? And then do they have a fever? Because that could mean some kind of infection. So for these patients, and this is a lot of GI bleed stuff going on up here. I mean, we transfer people almost every other week with the GI bleed up here in Ely. So it's either vomiting out front or pooping out the back, and it's blood, or it's dark terry. It's pretty common in the elderly population. So we want to monitor and maintain the airway, breathing, circulation. Put them in a position of comfort, which is usually fetal or sitting up, whatever's comfortable for them. Consider oxygen, especially if they're hypoxic. Their O2 sat might be a little bit low. They're just kind of looking pale. We can put them on some oxygen because they're probably lacking, like maybe they're bleeding internally and like they're going to some shock. So monitor the patient's vital signs and mental status frequently. Be alert for changes, provide emotional support, and notify EMS of any changes in their condition. All right, renal emergencies. So renal failure patients use hemodialysis to filter toxins out of their blood. We want to address life threats in these patients as we would any other patients. And we'll talk about what some of these could be. They're usually prone to like low blood pressure, cardiac dysrhythmias, nausea, vomiting, and bleeding from access ports that they have. So the patient on hemodialysis, the patient who has renal failure doesn't have the kidney's ability to filter waste and excessive water from their blood. Because of that, they undergo what's called hemodialysis, commonly just called dialysis. They usually go to a center for this, and they usually do this on a regular basis, like 3 times a week. The patient's blood flows through the dialysis machine, where the machine filters it, just like your kidneys would be able to but their kidneys can't. So the patient should not miss a dialysis appointment because missing one treatment can result in really adverse conditions for our patients. And sometimes we do get called to these patients. So this is a hemodialysis machine. There's ports coming out. One port, the blood comes out, it goes through this machine. It filters the blood for them, and it goes back up and in through the other port. And so it filters their blood, gets excessive fluid, gets rid of all that excessive stuff that's not supposed to be in there, just like our kidneys would do. People, if they're on this for a long period of time, will have what's called a shunt or a fistula. Usually it's in their arm. We're not going to take a blood pressure on that side. That can damage that access site, and we don't want to do that. So be aware of that. Life-threatening things that we can be called for with this: low blood pressure, nausea and vomiting, so they can get dehydrated, irregular pulse, and they can go into cardiac arrest with this, as well as bleeding from an access site, which we're going to stop just like any other bleeding. Difficulty breathing, lethargy. So they're just kind of low key, not doing much, not feeling good. The calls that I've been on with hemodialysis patients who have missed one are like their heart skipping a beat, or their heart is off, shortness of breath, that type of stuff is the complaints that I've had from these people. Sometimes on that initial treatment, they can get swelling of the brain as well. So with these patients, monitor and maintain their ABCs. If they are bleeding from a shunt, you can stop the bleeding. Position of comfort. If signs of shock are present, have them lie flat. If it's difficult breathing, have them sit a little bit upright. Apply high flow oxygen, however you need to, not a rebreather, bag valve mask. Monitor the patient's vital signs and mental status frequently. Be alert for changes in their condition. Provide emotional support, and notify EMS of any changes in their condition. All right, so which of the following is an example of a general medical complaint? I feel weak. This would be a specific. My chest hurts. This is general. I'm not feeling good. Which of the following patients may be in anaphylactic shock? Runny nose, we can handle that. Localized redness, blah. Patient with hives and trouble breathing, that's the one we're giving an EpiPen to. Right? Tongue swelling up, they're wheezing, they're hoarse, can't talk, can't breathe, they're anxious. EpiPen. When palpating the abdomen, we're going to palpate the quadrant with the pain. We have 4 quadrants, right? We have a left upper quadrant, a right upper quadrant, a left lower quadrant, and a left and a right lower quadrant. So whatever has the pain, we're doing last, which would be the 4th. Okay. How was that one? Everybody awake on me?
Yeah, it was pretty good.
I'm gonna hit pause.